Thanks a lot for inviting me. So I'm going to be discussing colorectal cancer screening, some of the updated guidelines, why should we get screened, and then, how often should we get screened? And as everyone knows, this is National Colorectal Cancer Awareness Month. So this is just a little introduction. So colorectal cancer is a common and lethal cancer and one of the leading causes of cancer death in the United States. Approximately 4.4% of men, so that's 1 in 23, and 4.1% of women, that's 1 in 25, will be diagnosed with colorectal cancer in their lifetime. So that's a pretty dramatic statistic. And then I've actually included on the bottom left-hand screen, this is actually a segment of the colon, and then these little growths which are coming from the colon wall are actually polyps. And we're actually looking for precancerous polyps. So why should we get screened, and why does screening take place? So precancerous polyps occur in about 30% of men and up to 20% of women. Colorectal cancer incidence and mortality rates have actually been declining in the United States, likely due to increasing uptake of screening. So now I think the screening methods are being more frequently used, and I think that's why we're kind of seeing these lower rates now. So screening tests can improve disease prognosis by identifying early stage colorectal cancer that is easier to treat and has a lower mortality rate than colorectal cancer detected after symptoms develop. Screening can prevent colorectal cancer by detecting and removing these precancerous polyps before they progress to colorectal cancer. So assessing the risk for colorectal cancer. So the first step in screening is identifying the patient's level of risk for colorectal cancer, because level of risk impacts screening recommendations. And for this purpose, patients are generally determined to be either at average risk or at increased risk. I've actually included the 4 of the main categories that put someone or an individual in the increased risk category. So the first one is a personal history of colorectal cancer or a personal history of precancerous polyps. So those individuals would be categorized into the increased risk individual group. If you have a family member with colorectal cancer, so which family member is it? Is it a first degree relative? So one of your siblings, your mother or your father, or is it 2 of your second degree relatives? So that could be an aunt, an uncle, and then the age of diagnosis. So the earlier the diagnosis of your first degree relative, that has an impact on when you should be starting to screen for colorectal cancer. And I kind of addressed that a couple of slides down. And then family members with known genetic syndromes. So there's actually a variety of genetic syndromes that predispose you or increase the risk of an individual developing colorectal cancer. And once that genetic syndrome is identified, they can be put into the increased risk individual category and then determined at what age should they start colorectal screening and how often should the screening occur. And then if you have a personal history of inflammatory bowel disease. So inflammatory bowel disease includes ulcerative colitis or Crohn's disease. And both of these disease processes also increase the risk or likelihood of an individual developing colorectal cancer. So these individuals are identified, and then based on the age of diagnosis, that's when the screening starts, and the frequency or how often to get the screening is also determined based on how severe the inflammatory bowel disease is. So when should we initiate screening? So the USPSTF actually found adequate evidence to suggest that screening in adults between the ages of 45 to 49 years provides a moderate benefit. So that's actually why I've bolded this here, age 45. That's actually a recent change that was made last year. And up until last year, we were actually initiating screening in average risk at 50 years. But the US Preventative Services Task Force and the American Cancer Society have both recommended starting to screen average risk individuals at age 45 years, because we've noticed that we're seeing early colorectal cancers. Increased risk individuals with family history of colorectal cancer should begin screening at age 40 years, or 10 years before the first degree relative's diagnosis of colorectal cancer. So if you have a first-degree relative, for example, that was diagnosed with colorectal cancer at 52, then that individual would undergo screening at 40 years of age. But if you have a first-degree relative that was diagnosed at 48 years of age, then that individual would actually undergo initial screening colonoscopy at 30 years of age. And as I've mentioned on the previous slide, individuals with genetic syndromes that predispose them to colorectal cancer should discuss when screening should start and how often their screening should take place with their gastroenterologist or their provider that's performing colorectal cancer screening. That's because there's a variety of genetic syndromes and different organ systems are involved. And I think that discussion should be held with the provider who's doing the colorectal cancer screening. And then what tests should we choose? So I think most providers would choose a colonoscopy, and that's because most society guidelines suggest that's actually the highest tier recommendation in most societies is a colonoscopy. And I put here in brackets every 10 years, every 5 years, every 3 years. So every 10 years is actually an individual who does not have any polyps on initial screening colonoscopy, who is of average risk with a good bowel preparation, meaning that their colon was completely clean and the provider can comfortably say that he or she did not have any polyps. And that would be an individual who we would recommend repeating the colonoscopy in 10 years. So someone for 5 years, that would be someone who has a precancerous polyp, so up to 2 precancerous polyps that are less than 1 centimeter in size. Then those individuals can undergo repeat colonoscopy in 5 years. And then I've put 3 years here. Those are actually individuals who have 2 or more precancerous polyps or a precancerous polyp that is actually greater than 1 centimeter in size. And those patients would actually undergo colonoscopy every 3 years. And then there's a few other kind of modalities that we can also use to perform colorectal cancer screening. So these are actually tests that I would kind of keep in patients who are unwilling or unable to undergo colonoscopy, with the understanding that if the below test is positive, then a colonoscopy needs to be performed promptly if the test is positive. And when I say unwilling or unable, I mean these are patients that have significant other comorbidities or illnesses. So things like significant heart disease or significant lung disease that makes them have to use oxygen at home. These are kind of patients that I would say that maybe one of these 3 tests would be suitable. So the first one is fecal immunochemical testing. So that's FIT testing. And that we actually recommend performing on an annual basis, so every year. And then there's FIT DNA testing. So that's the Cologuard testing. And that we usually recommend every 3 years. And then there's a CT colonography, which is the virtual colonoscopy, which is performed every 5 years. And that actually requires the bowel preparation, but obviously is not an invasive, we don't insert the colonoscope, and it's actually CT scan. And if any of these 3 tests are positive, then that should lead to a patient undergoing a colonoscopy. And then when should we stop screening? So we usually continue to screen for colorectal cancer through the age of 75 years of age. Recently, over the last couple of years, we've actually also now increased the age, and we're saying that patients that age between 76 to 85 years of age, we individualize the decision about whether to continue screening based on factors including the patient's preferences, prior testing results, and comorbidity. So if the patient has had a history of multiple polyps in the past or has a strong family history of colorectal cancer and is otherwise reasonably healthy, then I think, someone who's 83 to 85, they can continue to undergo screening. If someone has a lot of other illnesses, then I think, those individuals are the ones that maybe we should kind of say that, the risks associated with screening outweigh the benefits. And then all society guidelines actually recommend that we stop screening in individuals that are older than 85 years of age, no matter how healthy or well they are. And I think that's actually the end of this. These are some of the references. So all of these are actually updated guidelines from the main society guidelines. Thanks a lot. So I'm actually going to pass it over now, I think, to Dr. Nizin.
Thank you very much, Dr. Patel. That was excellent. Just one comment on the Cologuard test, which has become very popular. The Cologuard test is 92% accurate if you have a colon cancer, but it's only 40-something% accurate if you have a polyp. So it really misses polyps all the time. When people have a negative Cologuard test, they can still have polyps and don't realize it. It is not the most sensitive test for polyps, even though when you watch the advertisement, it always quotes the 92%, which is if you have a cancer. I'm going to go to my slides. So when people think of a surgeon, they often think that they're doing surgery and nothing else. But the role of the surgeon is actually fairly complex. And it overlaps all of these topics. You have to review documents, might be x-rays, lab work, pathology. You consult with others because surgery for cancer is a team effort. It's usually not a solo event. So I would consult with my gastroenterologists, oncologists, maybe radiation therapists, sometimes urologists, stomal nurses, genetic counselors. There's a large number of people that you consult with when you have a colon cancer that the surgeon is supposed to consult with. And then finally, you actually consult with the patient, the family, and recommend a specific plan. And part of that plan is talking about the benefits and risks of all the different recommendations. Why is surgery recommended and what it is? I'll get into that a little bit later. But then the surgeon actually performs surgery, which is a few hours out of this whole complex event. You have to take care of the patient in recovery. You have to treat them for complications if any occur. You have to explain the results of their test, whether it's genetic, pathology, CAT scans, whatever it is. And then you have to become involved in future surveillance. Sometimes the gastroenterologist does surveillance, sometimes the oncologist, and sometimes the surgeon. So all of these aspects are part of being a competent surgeon. Patients often ask me, have I asked enough questions during my consultation? And I've listed the usually top questions that people really should have answered when they consult about colon cancer. Typical questions: is surgery the correct and only option? Are there other options? What technique will you use, whether it's open, laparoscopic, robotic, maybe advanced colonoscopy? Is the treatment going to be curative or is it palliative, which we'll explain later? Will I need a colostomy? And is it permanent or temporary? Can you please explain cancer staging to me? Do I need any other treatments before or after surgery? Explain what's going to happen in the hospital. What can I expect after discharge? And explain all the possible complications and how you prevent them. These are topics that really should be explored during the consultation. This is considered an adequate exam. So what are possible surgical outcomes? The one that everybody hopes for is cure, where the tumor is removed. Maybe you need other treatments, but there's no recurrence of cancer 5, 10, 15 years later. So a cure is not something that happens that day. A cure is something that you know 5 or 10 years later when there's no recurrence. But then there's palliation, where you may not be able to cure the disease, but you might have to do something to assist the patient. So for instance, they're bleeding, they have a blockage, and you have to do some palliative procedure, which you know is not curative, but it deals with an immediate problem that you can solve. And then, of course, surgery sometimes has to deal with critical problems. There's a perforation, a hole in the colon. There's sepsis. There's sepsis in the abdomen, peritonitis. There's a blockage. The patient's having massive bleeding. So these are critical problems that need immediate, not let me think about it, but they need immediate, often within hours or minutes type solutions. And in talking about cancer, I like that Dr. Patel talked about screening so much. It's so important. The nice part is when a cancer is found early on, before it spreads anywhere, there's a very good survival rate. And probably 40% of patients fall into that category. But then you have patients where the disease is a little bit more advanced and perhaps it's gone to lymph nodes or through the wall of the bowel. And that's also about 40% of patients. And they have to get other treatments. And depending on what type of treatment, their response rate, they don't do as well as the earlier group, but they still do fairly well. The ones that are the problem is where it's spread distantly to the lungs, liver, ovary, elsewhere. And that's at least 1/5 of the patients we see, because colon cancer can spend 3 years before it causes any symptoms. So in that time frame, patients can develop metastatic disease and it's totally silent. They would never know it. They don't do as well. So the standard of surgical care is that you have to have adequate margins, and I'll show you a picture on the next slide. You have to remove local lymph nodes so that the pathologist can assess the disease to see if it has spread to any of the local lymph nodes. And you definitely want to have minimal complications. So here's the idea of colon cancer surgery. You see in the red, the blood vessels. You want to take a main feeder blood vessel that feeds that segment of the colon. The little green dots are lymph nodes, and you want to get adequate lymph nodes so that the pathologist can tell you how well the surgery went. The minimum is 12, but you always want to get more than 12 lymph nodes. But then you need a longitudinal margin, which means you've gone above and below the tumor in terms of a piece of tubing. And then there's also called the radial margin, so you've gone around it and not compromised. If the tumor is touching the abdominal wall or some other structure, you want to make sure that you've removed it entirely. That's the radial margin. And then, depending where the tumor is in the colon, you take different blood supplies in different segments. So patients will often ask how long a piece of bowel you're going to take. The colon is approximately 5 feet long. When you do a resection, you're usually taking at least 1 foot of colon out because you have to go by the blood supplies, which this picture demonstrates. But then we get to cancers of the rectum, which are very different than cancers of the colon. I know our oncologist is going to talk about this, but the surgical viewpoint is that the rectum, which is about 8 inches in length, is divided in thirds. If you have a cancer in the upper third, you can remove it. There's no colostomy, and there's usually a good result. If the cancer is in the middle part of the rectum, you usually have to do a temporary colostomy because the leak rate of your anastomosis is so high that if you just hook it up without a colostomy, it will leak, and then the person will get a permanent colostomy. But the problem is when it's in the lower 1/3 of the rectum, the disease is so close to the sphincter muscles, which you see in this picture, that you have to give the person a permanent stoma. And I know oncology will talk about how we treat these things prior and after surgery. So I'm not going into that. Classification, or the staging of the tumor, People often have an idea that it's this antiquated system of A, B, C, or 1, 2, 3, and that isn't how tumors are staged anymore. Tumors most commonly are staged T and M. T talks about the depth in the wall, which this upper picture shows how deep the tumor goes in the wall. N talks about the lymph node status, and M is metastasis, distant disease. But then you also talk about the grade. Do the cancer cells look bizarre, or do they look similar to what you'd expect? There's microsatellite instability. And that is important because that's an indication of how well DNA is repaired in your body. And we look for one of the syndromes called Lynch syndrome when we look at this. But then there are also mutations in RAS and BRAF, and that often talks about how well people respond to certain chemotherapies. So all of these are actually part of the stage. So the 1, 2, 3 or ABC version of the past should be left in the past. And you really want to have staging explained in much more detail when you have a cancer. Everybody loves robots. Here's a picture of the robot, and you have to realize it's a cartoon because here's the surgeon sitting, here's the robot not attached to anything else, and someone pointing at the TV, which no one does. Here's the actual robot in practice. And you can see this robot has 4 arms, and each of the arms is covered by this plastic sterile coating. The surgeon is often a panel, and there is an assistant surgeon close to the patient because some of the instruments of the robot have to be swapped in and out, so that you need someone standing near the robot. But there also are advanced techniques that we can do with our colonoscope to prevent having someone have surgery. So for instance, if you have a rectal cancer that is small at one of the early stages, sometimes we remove it by colonoscopy. And here's what's called a submucosal resection, which is one of the advanced techniques where you mark it with the colonoscope, you lift it up with an injection, and then again with the colonoscope, you remove it so it can be analyzed by the pathologist. So some early cancers are treated nowadays even without surgery by advanced colonoscopy techniques. Another technique is when a patient is obstructed and they have a lot of other medical problems, you don't want to operate on them, but you want to relieve the obstruction. So one of the techniques here is placing a stent. So through the colonoscope with X-ray, a small sheath, a guide wire is sent, and a stent is put in which can expand. This is done sometimes because there are issues with this technique, but it's one of the parts of our armamentarium to treat different types of advanced cancers. Another technique is called TAMIS, where this is basically laparoscopy through the rectum, so that there's no incision made, but this bluish looking instrument on the screen is placed at the rectum, at the anus, and instruments are passed through it, similar to laparoscopy, to remove lesions in the rectum. And here, of course, is more conventional surgery, how the bowel is connected with a staple gun. And there's an anvil, there's a stapler, and you can see in the part that's marked D, the staple gun has now been closed, the staple's fired, and you have a row of staples surrounding them. The problem with this technique is if it leaks. So here is an X-ray, what's called a gastrograph enema, and with a red arrow, it's showing the leak, which is a disaster. It means the surgical technique failed, and the patient will then need a colostomy, and this will need to be redone if possible. And finally, here's a picture of a colon where the bowel has been connected back together, and a picture of a colostomy, again, a cartoon, where it was not connected. But in this picture, it's temporary because the rectum and the colostomy can now be rejoined at a future operation. So this is a temporary, not a permanent colostomy. And I think I can stop sharing.
Perfect. I think I'll take over. Great presentation, Joel. That robot's so cool. It makes me want to be a surgeon. Are you guys all?
Likewise.
Hopefully. Thanks for having me, guys, and thanks for coming. It's great to see everyone here. So my name's Kevin Wood. I'm one of the medical oncologists here at Valley. I see most of the gastrointestinal cases, so most of the colorectal cases come to me. So my talk tonight is on colorectal cancer and chemotherapy. What are kind of the highlights to lead with? So here's kind of an outline of what I'm going to be talking about over the next 10 or 15 minutes. First, Joel kind of started hinting at this, but I wanted to talk about staging. As an oncologist, that's kind of the most important question for me because it really dictates what possible treatment we should use and how to cure the patient. Next, I wanted to talk both about the treatment for colon cancer and rectal cancer. As Joel said, the treatments are very different, and I think it's important to distinguish between the two. And then finally, I wanted to talk about some of the advancements we've made in the past 10 years or so with molecular mutations and genetics. We're doing some really cool things at the molecular level now, and it's predicting what kind of treatments might work, such as immunotherapy, which we'll talk about, but is very different than chemotherapy. And it's really been helpful in understanding these tumors a bit more. So first, staging. When I see a new cancer patient come over from Dr. Nizin's office or one of the other colorectal surgeons, I always have two questions. The first is, what is it? And that usually is answered by either the biopsy or the pathology from Dr. Nizin's procedure. I think it's important to distinguish between two different types of cancer that we see in this area. So with rectal and colon cancer, in almost 99% of cases, the type of cancer is something called adenocarcinoma. This is very different from anus cancer, which is a squamous cell carcinoma, which is treated very, very differently than rectal and colon cancer. So very important to look at the pathology once we get it to confirm where this started from. Once we know that, the next question is, what is the extent of it? What is the stage? That's going to tell us, can we cure this? And it's going to tell us what is the best treatment to use. So the way I think about it, Joel spoke about the TNM, and this is kind of a simplified version of that. But the way I think about it, stage 1 is when the tumor has not invaded through the wall of the colon. Stage 2, it's invaded through the wall. Stage 3 is when the tumor has started invading into the lymph nodes, which is kind of like the drainage system of the colon or the rectum. And then stage 4 is when it's metastatic, when it has spread to another organ somewhere else in the body. And usually when it's done that, we are unable to cure it in most cases. So now moving on to treatment, I was going to talk about colon cancer first. First, I wanted to kind of highlight how we look at new cases of colon cancer here at Valley. And I'm really proud of our approach. We take a team approach, as Dr. Nizin was kind of alluding to as well. But this is kind of the typical approach for any new colon cancer case. So usually they see someone like Dr. Patel first, one of the gastroenterologists, for a colonoscopy. They get a biopsy done and then are referred over to Dr. Nizin's group. They have their cancer removed. And then before they see me or one of the other medical oncologists, their case is presented at our colorectal multidisciplinary tumor board. So this is a big group where all the medical oncologists, radiologists, surgeons, the pathologists, we all get together and discuss each new cancer case. We make sure we go through all the details and come up with the exact right plan to make sure we're doing everything we can to cure this patient. Afterwards, they come to see me, and then I think it's nice that we have this full plan in place so we know we're doing everything right. So in colon cancer, I think there's kind of two settings to think about. So the first one I'll talk about is the curative setting. So these are patients that Dr. Nizin or his group is able to operate on and get rid of the cancer completely. And they come over to me to consider chemotherapy in certain cases, specifically stage 3 colon cancer when there's some lymph nodes involved. And we use chemotherapy to lower the risk of the cancer coming back. So in this curative setting, when the cancer's gone at this point, there's only one chemotherapy regimen that works. It's kind of easy for me. And that regimen is called FOLFOX. It's made up of 2 drugs called 5-fluorouracil and oxaliplatin. I think the nice thing about this is you won't lose your hair, which is nice. The main issue I warn my patients about is nerve issues. So after each treatment, you'll notice you're very sensitive to cold. You can't drink ice water, and it's worse in the winter. You learn to avoid cold things for the first few days after each treatment. The other thing is you can develop peripheral neuropathy, which is where you can get tingling or pain in your toes and fingers. That to me is the most concerning. It's the only symptom that can become permanent, but something we watch out for very closely. And we usually stop the drug if it starts developing. This regimen, kind of the only annoying thing about it is it requires something called a port, which is basically it accesses the central vein right in your chest because you have to go home wearing a fanny pack with this 5-fluorouracil drug infusing into you for 48 hours every 2 weeks. So the logistics are a little bit obnoxious, but overall it's a well-tolerated regimen. And usually we use this for about 3 to 6 months. So usually it's not too bad, and then you kind of move on with your life, and we've lowered the risk of the cancer coming back as much as possible. The other setting is the palliative setting. So this is cases where the cancer has already spread to another spot before they reach us. And in a lot of these cases, unfortunately, we can't cure them. And what we're doing is trying to prolong people's lives to shrink the cancer as much as possible and make their lives as good as possible. Here we have a couple more options to treat these patients. So chemotherapy, there's kind of 2 regimens we can consider. The first is the FOLFOX, which we talked about before. The other is something called FOLFIRI. You'll notice there's still that 5-FU drug, but then instead of the oxaliplatin, you have something called irinotecan. The interesting thing is both of these drugs combinations work equally as well. So you don't go wrong which one you choose. The reason you would choose one over the other is because of the side effects you want to avoid. So with FOLFIRI, unfortunately, you develop hair loss and diarrhea. And so for a lot of my patients, that's kind of the game changer. They don't want to lose their hair right when they're starting. So typically they choose the FOLFOX first, unless they have nerve issues to begin with. In addition to the chemotherapy, there's some targeted therapies that are often added to the chemotherapy. These drugs don't seem to work in the curative setting. They don't provide benefit, but here they do. So there's 2 options we typically choose from. The first is a drug called Avastin, which is actually very well tolerated. And the way it works is it kills off the blood vessels that are forming to feed a tumor. So once you kill off the blood supply, some of the cancer starts dying off because it doesn't have a blood supply feeding it. The other drug we have is something called cetuximab, which targets a receptor on the cancer cells. I tend to avoid this drug up front because it can cause very, very terrible acne. My patients complain they look like they're teenagers again. It kind of makes their life miserable. So we use it if we absolutely need to, but I tend to use the Avastin first. So finally, rectal cancer, the last treatment I wanted to talk about. And Dr. Nizin was kind of alluding to this as well, but the treatment for rectal cancer is very different than colon cancer. The treatment for colon cancer typically involves surgery and then plus or minus chemotherapy. We typically do not use radiation in colon cancer. Very different in rectal cancer. So treatment almost always involves chemoradiation at some point. We have an old method that we are using kind of in the last few years that's starting to be weaned out. And that was using chemoradiation first for around 2 months, then doing surgery with Dr. Nizin, and then doing 4 more months of chemotherapy alone. So about 6 months total of treatment. However, we're starting to transition that out with a new method. And this way we're using chemotherapy first, actually, for 4 months, and then chemoradiation and surgery. I'm really proud of Valley because I feel like we're leading the way in New Jersey and kind of making this transition. And a lot of the data coming out from big academic centers seem to suggest this works better. And the reason we think it does is when you use chemotherapy first, if you think about it, radiation and surgery focus on a very finite area, right? It doesn't treat the whole body. Chemotherapy does. So it treats the whole body and can start killing off any microscopic cancer cells that are there prior to cells that are there. So the chemotherapy we use is called FOLFOX, which is the same that is used in colon cancer. Stage 4 in the palliative setting, treatment is exactly the same as colon cancer. So finally, molecular mutations in genetics. We've made some really exciting advancements in the last few years. It's becoming increasingly important. So the main mutation I wanted to talk about was a microsatellite mutation. So this is a mutation that involves the genes that are involved with repairing DNA. When you have this mutation, it's commonly associated with a condition called Lynch syndrome, which is a genetic syndrome that's associated with an increased risk for colon cancers and other types of cancers. The reason it's also important is people with this mutation tend to have a great response to something called immunotherapy. One drug, for instance, that's very popular is called Keytruda. It tends to work very well in people with microsatellite mutations. So what is this? So immunotherapy is very different than chemo. The way I think about chemo is it's basically just poison, right? It kills some of the cancer cells, but it also kills your healthy cells and you develop a lot of bad side effects off. Immunotherapy is very different. So it doesn't attack the cancer directly. Instead, what it does is it activates your own immune system to attack the cancer. There are two common drugs that we use that kind of came on the market first. One is called Keytruda, and then one is called Opdivo. And in people with these microsatellite mutations, it has really been a game changer. So it tends to work better than chemo. It works in about 80 to 90% of patients. And the exciting thing is, unlike chemo, which at some point the cancer kind of outsmarts, immunotherapy tends to keep working years and years into it. So it's really exciting to see. It's been a huge advancement in colon cancer. Interestingly, if you do not have this mutation, there is a 0% chance of responding to immunotherapy, which is often very disappointing for a lot of my patients to hear. And I think that's it. Thank you very much.
Thank you so much. We have a few questions, so hopefully we can get through some of those. The first one was, what's the difference between polyps and precancerous polyps? How is that determined? And do they remove all the polyps that they see during a colonoscopy? How does that usually work?
I can answer that question. So yeah, that's actually a very good question. So there are some benign polyps, things like what we call hyperplastic polyps that are considered benign. And typically they are removed during the colonoscopy, and then they're actually reviewed under the microscope by a pathologist who determines, he or she can say, yes, this is a benign polyp, and so we don't need to kind of put it into a surveillance category.
Okay, thank you. Another question is, what is the greatest barrier for screening for people coming for colorectal screening? From your experience, what's keeping people from coming to be screened?
So I think, I mean, Dr. Nizin, I'm sure can also answer this, but I think a couple of the main things that I get from patients are, one, the fear of going under anesthesia for the procedure. I think that's one of them. And then the other one would be, fear of it being an invasive procedure. And I think the third part is the bowel preparation. A lot of people don't like the bowel preparation. So I think, and the bowel preparations have actually improved drastically over the last few years. So now the preparation's a lower amount of quantity, so less amount to drink. And from what patients tell me, I haven't had a preparation myself, but from what patients tell me, I think it tastes a lot better than some of the older ones, which were a larger quantity. I don't know if Dr. Nizin wanted to add on that as well.
I believe the dislike of the bowel prep, because people's friends will tell them horror stories about how bad it is or how terrible it was or how they stayed up all night having diarrhea, and will scare them from doing a procedure which is very important for their health. The fear of bleeding, perforation, or anesthesia are usually lesser concerns. The bowel prep is usually the worst. And as Dr. Patel indicated, the preps that we're using nowadays are much nicer than in the old times.
Thank you. And how long does colonoscopy usually last, the actual procedure? There's another question that says, that asks, is it usually performed in the hospital, in a center, in an office?
Colonoscopy can be performed in any of those locations. If it's in the office, then you have to have an anesthesiologist, recovery room, and all the proper equipment. but most of us do it either in the hospital or in a surgery center. And it depends how difficult it is to get around the curves of the colon and how carefully you then examine the colon as you withdraw the scope. But an average would be 20 or 30 minutes for the exam.
Okay. Thank you so much for that. Is there a particular group or ethnicity that's at the higher risk for colon cancer? Not sure who would want to answer that. Dr. Wood?
Yeah, so good question. I mean, I think we look more at family history. So that's the big risk factor here, especially with first degree relatives. They really need to be screened much earlier.
All right, and then is there a particular diet associated with a higher risk for colon or colorectal cancer? And if so, the opposite of that, what's recommended kind of for prevention, if there's any studies on that?
You know, after my patients are cured from colon cancer, I tell them a few things to lower the risk of the cancer coming back. One is avoiding red meat. Two is making sure you have enough fiber in your diet. There's some slight evidence for aspirin use as well, but there's risk with aspirin too. So that's kind of a hit or miss thing. But the fiber and the avoiding red meat are the big ones, I think.
Does that include exercise as well?
Yes.
In addition, people who eat a lot of processed foods, so for instance, luncheon meats, foods with nitrates or preservatives or a lot of chemicals added, are at higher risk. So for instance, in New Jersey, it is against the law to spray a salad bar with nitrates. No one has ever been persecuted in New Jersey for spraying salad bars with nitrates. So there are more than 110,000 chemicals that are allowed to be added to our food. The majority of them have never been studied to see if they cause cancer or not.
Wow.
Industrial chemicals that increase your risk also, such as the dyes used in dyeing material or in printing. So there are chemical exposures that also increase your risk. I have a number of patients who were exposed to Agent Orange in Vietnam, and they have a higher risk. There's a screening program now for people who were exposed in 9/11 to all the toxic chemicals released, and they have a higher risk. So there's certainly chemicals in the environment, in addition to foodstuffs, that increase our risk.
Thank you. We have a question about precancerous polyps. They had found precancerous polyps during his last colonoscopy. What interval should his next colonoscopy be when his father was diagnosed with colorectal cancer at 60?
So I think, I mean, so just to get that right, so I guess, so the patient, the individual who's asking the question has a personal history of polyps as well as his father getting diagnosed with colorectal cancer at 60?
Correct.
So I think, so if his father was diagnosed at 60, his first colonoscopy should have been at 40. And then depending on how many polyps, if he had no polyps, his screening would be every 5 years. But if he also has a personal history of polyps, depending on kind of the number of polyps, what kind of polyp, the size of the polyp, if the polyp was taken in one piece or multiple pieces, then his timeline could change. It could be anywhere between 6 months to 5 years.
I see. Thank you. And then Dr. Patel, have you had patients from our fast track program? And if you can talk a little bit about that.
So yeah, so the fast track program is actually, it's a nice little program that's been created for patients who are relatively healthy, don't really have significant other illnesses, and it actually prevents them from coming into the office before a colonoscopy. So, you know, our program will discuss all the preparation and even the procedure and everything with the patient. and then the patient can come directly for the actual colonoscopy procedure.
All right.
More than 400 people last count have gone through the fast track program. It's very wonderful.
That's wonderful. There's another question here. I, in the past, have had non-cancerous polyps, but was advised to follow up colonoscopies every year. Is that overly aggressive? I guess it would depend on his family history as well, or?
Yeah, I think that, family history, and also sometimes if the provider doesn't feel as though the bowel preparation was adequate enough. So if he or she didn't, the provider didn't feel as though the preparation cleaned out the colon completely, then, there's different kind of timelines. So mine was a kind of a broad summary, but I think that it's pretty individualized when it comes to those kind of things like bowel prep and stuff like that.
I also recommend to patients when they have a procedure and a pathology report to keep an actual paper copy of the report, because you might switch doctors, you might have to show it to the oncologist, the surgeon somewhere else, and the patient might describe it in one way, but the pathology report often gives additional information that the patient may not realize is important. So the actual printed page, everyone should carry their pathology reports with them when they visit other doctors.
Thank you. How many rectal cancer patients does Valley treat annually? And how many rectal cancer surgeries are usually performed at Valley annually? I don't know if you have those numbers.
So I can give you an estimate that there are several hundred colon rectal cancers treated by surgery at Valley Hospital every year. That doesn't include the ones that are treated non-surgically with palliation or chemotherapy. Of the more than 200, what percentage are rectum? Rectal is probably about 1/5. You think that's a good estimate, Dr. Wood?
Yeah, I would agree. I feel like we're presenting around 3 or 4 each month at our tumor boards, around there. But most of the cases are colon.
There is a question here about risk for colon cancer. Does hemorrhoids increase your risk for colon cancer?
That's actually a good question. I think that hemorrhoids in itself don't, but if you have hemorrhoids, maybe you've had a long history of things like constipation, maybe your fiber intake is inadequate, and those things could increase your risk. But I don't think having hemorrhoids in itself increases the risk. But I think the factors that cause the hemorrhoids does increase the risk of someone developing colorectal cancer.
The additional aspect is if you're bleeding and you always attribute it to your hemorrhoids, you've not been investigated to see what the actual cause is. So I'll see a 40-year-old who tells me, I've been bleeding for the last 6 months from my hemorrhoids, and it's not their hemorrhoids.
It's a very good point. When you're talking about family history and colorectal cancer, there's a question here if it's other history, it's history of other cancers, does that also increase their risk?
Yeah, good question. So it's definitely important to ask about other cancer types as well. For instance, like with Lynch syndrome, for instance, you see not only colon cancer, but uterine cancer and other cancers as well. So I think it's important to get a full family history, not only of colon cancer, but everything, because there's many genetic syndrome out there that people are at risk for.
Okay, so I think this might be for you too, Dr. Wood. A sister was diagnosed in February, told that it was important for the blood relatives to get tested every 6 to 7 years. Is that enough to follow the family members?
Possibly with colonoscopy screening, I think they mean. So you guys might be able to answer this a little bit better, but I know a lot of the guidelines out there say for first degree relatives that are affected, like if your dad got diagnosed, for instance, your colonoscopy should start 10 years younger than when he was diagnosed. And yes, you should probably follow a little bit more closely, but probably a lot of it kind of depends on what you're finding with each colonoscopy, I would assume. Do you guys agree?
7 years is too long. Five is probably a better number.
There's another question here about chemotherapy regimen. The difference between a 3-month regimen and a 6-month regimen, and what does it depend on?
Yeah, it's a great question. So there was a huge trial that came out just a couple years ago called the IDEA trial, and it looked at 3 months versus 6 months of chemotherapy after removal of stage 3 colon cancer. It seems like there's kind of a low risk group and a high risk group, and it's kind of dependent on if the tumor invaded through the colon wall, we would consider that high risk, or if there's a certain number of lymph nodes involved, which is over 3. When you see either of those, it's considered high risk, and those patients tend to need 6 months of therapy rather than 3. There seemed to be a less chance of getting a complete cure if you only did 3 months in those high risk patients.
Thank you. I'm getting a lot of questions about the frequency of colonoscopies, which I know you've all touched on at some point. And just to let the viewers know that we will be posting this presentation. So if there's anything that you missed, you could always take a look at the presentation again. I have posted where it will be, www.valleyhealth.com/tuneintohealth. So that would be at the end of this week. So we do have a lot of those. They did go over that. The panelists did go over that earlier. But if you want to just reiterate the newest guidelines for starting colonoscopies, the age to start, Dr. Patel or Dr. Wood?
Yeah, so I think the biggest recent change is reducing the initial age of colonoscopy in the average risk individual to 45 years of age from 50. And that's supported by two of the biggest societies, the American Cancer Society and the US Preventative Task Force Society as well. And that's in every ethnic group as well at 45 years of age. And then patients, just to reiterate again one more time, patients that have a first-degree relative, that they should start their initial colonoscopy at 40 years of age or 10 years younger than the earliest first-degree relative if it's before the age of 50. So if your first-degree relative was diagnosed at 48, then your colonoscopy would actually be at 38 and not 40. And then, as Dr. Wood said, there's multiple genetic syndromes, and those patients should really have a further discussion because their initial age can vary all over the place. It can be 13 years old, and it can also, some of the other syndromes, it can be at 25 years old, for example.
Thank you. There's a question here about colostomy. Is there any chance of not having a permanent colostomy with cancer of the lower third of the rectum? Does Valley emphasize preservation of function with rectal cancer surgeries? Dr. Nizin.
Those are two different questions. Preserving the rectum is very important. When it's at the lower 1/3, if it's at a very early stage, so it's small, well differentiated, no evidence of spread, it's possible that we remove it by the TAMIS or transanal technique and do not do a permanent colostomy. But it has to fit particular criteria to do that. In a more advanced cancer, the margins, the oncological treatment of it does not allow preservation of the sphincter. However, the colon rectal surgery, all the techniques to preserve the rectum are in our skill set. For instance, there's something called a pouch, where you actually take part of the bowel and fashion an artificial rectum out of another piece of colon so that you do not have a permanent colostomy. So it depends on what the stage is, where it is exactly. We try to preserve the function as much as possible, but you can't always do it.
And then there's another question here. When a surgeon's removing cancerous growth from the internal wall of the colon, is the only way for the surgeon to know whether the lymph nodes and the margins were involved is by removal and testing those, or is there any other way? to tell if those are clear?
So if you do a scan, an MRI, or one of the other types of radiological scans, you might see local lymph nodes that are enlarged, but it doesn't prove that they have cancer in them or not. You actually have to have the lymph node under the microscope to know if it has cancer or not. So if you see on a scan positive lymph nodes by MRI, PET scan, or one of the other modalities, ultrasound, it's a high chance that you're not going to know unless you actually have it under the microscope.
Okay. I think this would be our last question. Is there any impact of COVID on colonoscopy procedures? Like, what are we doing differently since COVID is here?
I think I think I don't know if the question is if it's safe to undergo a colonoscopy during COVID or, but
And
I mean.
And does it restrict the ability of someone to accompany a patient for the procedure?
So I think, so in our facility, so we perform colonoscopies, or I myself perform colonoscopies at Valley Hospital. We do testing on every patient prior to the procedure. So I think about 3 or 4 days prior to the procedure, and everyone is quarantined prior to the procedure. And then in terms of having an escort, so we don't allow escorts to come into the actual facility, but as soon as we're done with the procedure, we give the escort a call, and then he or she can come and pick up the patient after an hour.
There are a few exceptions. If the patient, for instance, is autistic, is deaf, only speaks a foreign language, and you have to communicate with them directly. So there are some exceptions.
Thank you. Thank you so much, Dr. Patel, Dr. Nizin, Dr. Wood, for your informative